Hello students, welcome to medical lecture series. Today is effective endocarditis. This is internal medicine and this is a lecture series dedicated to clinical officer students. My name is Dr. Machero. You are warmly welcome to this very important discussion. Don't forget to subscribe at the end of this video and to have a notification on for further update in the upcoming lectures. To remind you students, this is a very fundamental topic you have to understand because in your practice you'll encounter some patient with infective endocarditis. Therefore, having a fundamental knowledge of how to identify the patient with infective endocarditis, that is how to make a diagnosis, how to make a differential diagnosis to exclude other disease which mimic infective endocarditis, and how to finally manage this patient is very important as far as medicine is concerned. So in this discussion, student, we have the following parts which we have to pass through. We have to pass through introduction. This is very important to be introduced with effective endocarditis before we proceed. After that, we have to pass through epidemiology of effective endocarditis. After epidemiology, we have to see the causative agent, that is etiology of effective endocarditis. After etiology, we have to see what happened for the patient to develop infective endocarditis, that is the pathophysiology. After pathophysiology, we have to pass through clinical features. How does a patient with infective endocarditis present clinically? And after that, we have to pass through diagnosis. After diagnosis, we have to pass through differential diagnosis to identify other disease mimicking as infective endocarditis. After that, we have to see investigation modalities in patient with infective endocarditis. After investigation, we have to see how do we treat a patient with effective endocarditis. After treatment, we have to see the complication of effective endocarditis. Finally, we have to come to prognosis, prevention, or after prevention, that will mark the end of our discussion. And after that, we have to summarize that, to have the key point and to evaluate ourselves after this session. Okay, students, to start, I would like to define effective endocarditis. What is effective endocarditis? Effective endocarditis, this is an infection of the endocardium. Just saying an infection of the endocardium is very simple. The question is, what is the endocardium? When we are saying infective endocarditis is infection of the endocardium, we should know what is the endocardium. We say endocardium, this is the inner lining of the heart chambers. So the inner lining of the heart chambers, when they are infected, is what we call effective endocarditis. Generally speaking, effective endocarditis affects the heart valve. The heart valve which affected can be normal valve, that's the native valve, or prosthetic valve, that is the artificial valve. Sometimes effective endocarditis can also affect the blood vessels, and the congenital anomalies such as septal defect. When you have septal defect in congenital anomalies such as ventroseptal defect or atrioseptal defect, they can be infected with the bacteria, and that is what we call effective endocarditis. The most common cause of effective endocarditis, it is bacteria. And in the bacteria group, the most common are gram-positive bacteria. That is streptococci. Streptococci, this is a gram-positive cocci in chain, and the staphylococcus, this is a gram-positive cocci in cluster. So these are two bacteria which are the most common cause of effective endocarditis. Okay, as I said, effective endocarditis is commonly caused by bacteria. Therefore, effective endocarditis commonly caused by bacteria is simply termed as bacteria endocarditis. Again, to insist, bacteria are the most common cause of effective endocarditis. And in bacteria group, remember your friend, the staphylococcus and the streptococcus, those are the leading cause of effective endocarditis. Also to insist, we said as it affects the inner lining of the heart, which is the endocardium, it affects also the heart valve. That's why it presents with the heart murmurs. Remember, heart sound are produced by closing of the heart valve. So when you have inflammation of this valve, you will lead to abnormal heart sound. That's we say there will be heart murmurs. Again, because there is inflammation, don't forget fever is a sign of inflammation. That's why the patient will have fever. Also, there will be petechial, anemia, embolic phenomena. Of course, embolic phenomena, remember, when the heart valve are inflamed, so there will be turbulent flow of blood. We say the normal blood pattern flow is laminar. So when you disturb the valve, you lose that laminar blood flow, and the flow will become turbulent. Turbulent blood flow is a risk factor for thrombosis. That's why we say there will be embolic phenomena. And finally, these bacteria will vegetate. Vegetate meaning they will start to vegetate or to grow on the inner lining of the heart. That is the endocardial vegetation. Vegetation may result in valvular incompetence. Of course, this is a complication of valvular damage. That is the valve cannot close and prevent the backflow of blood. That is valvular incompetency. Sometimes inflammation can lead to narrowing of the valve, which will cause valvular obstruction. Valvular obstruction. Also, myocardial abscess, that is when the bacteria invade the myocardium. From the endocardium, they invade the myocardium and causing abscesses. That is myocardial abscess. After that, they can also cause myotic aneurysm. Myotic aneurysm, this is abnormal dilatation of the heart chambers. Of course, remember, aneurysm is abnormal dilatation. When the heart chambers are inflamed, they can be fragile and they have abnormal dilatation. Okay, in diagnosis of infective endocarditis, we say to make a diagnosis of infective endocarditis, there must be evidence of microorganism in the blood. Why are we saying there must be evidence? Because we said infective endocarditis is caused by bacteria, which are the most common, and in bacteria group, don't forget, the staphylococcus and the streptococcus are the leading cause. So there must be evidence of these bacteria within the blood. The second issue is because infective endocarditis leads to damage of the heart valve, so we expect structural damage in the heart valve. How do you see structural damage? We see it by using echocardiogram. That's why we say in echocardiogram there must be evidence of valvular damage. Of course, to differentiate, we have echocardiogram, which is responsible for structural function of the heart, and the electrocardiogram is responsible for functional abnormality of the heart. Treatment of infective endocarditis require a prolonged use of antimicrobial. Why antimicrobial? Because they are caused by bacteria, so to insist it is antibiotic, sometimes antibacterial. Because the heart valve are damaged, sometimes surgery may be required to correct the structural abnormality of the heart. Okay, we are moving on. We say generally infective endocarditis can be grouped into two types. We have acute endocarditis that is caused by virulent organism, and we have subacute infective endocarditis, which is caused by less virulent microorganism. Of course, the virulent microorganism, which are bacteria I'm talking of, they can affect the normal valve, that is a native valve, while subacute infective endocarditis is normally occurring in valve which are already damaged. For example, you have artificial valve, prosthetic valve, you have septal defect such as ventroseptal defect or atrioseptal defect. So you are likely to have infective endocarditis by less virulent organism. And because these organisms are less virulent, that's why you have subacute infective endocarditis. To summarize, we say subacute infective endocarditis occur in already damaged heart valve while already damaged heart valve, while acute effective endocarditis, which is caused by more virulent the strepto and the staph aureus, it can affect the normal valve as well. Epidemiology, we say generally effective endocarditis can occur at any age. As far as sex is concerned, men are highly affected than women. Of course, we see the risk factor which put men to be highly affected about twice as women. Among the people at risk, we say intravenous drug abuse and immunocompromised patient are at high risk. Why intravenous abuser? Remember, intravenous abuser, they do inject intravenous the drugs which they abuse in an sterile way. Remember, in the skin we have the normal flora, which is the staph aureus. So they have a high chance of introducing staphylococcus aureus within the blood, and the presence of staphylococcus within the blood can lead to infection in the endocardium. That's why intravenous drug abuse are at high risk. Also, immunocompromised patient, of course, normally we have bacteremia, but because we have immune system working properly, they tend to clear this bacteria. So when you have immunocompromised patient, this patient, they cannot fight well against bacteria within the blood, so they can be at risk of having effective endocarditis. Coming to etiology, generally we say the normal heart is resistant to infection. That's why we said in acute effective endocarditis, where the normal endocardium is affected, so to be affected, the causative agent must be also a very virulent bacteria. So generally, the normal heart valve is resistant to infection. Bacteria with fungi do not easily adhere to endocardial surface. Why? Because there is a constant blood flow which tends to wash away this bacteria and prevent adhesion of this bacteria in the endocardium. So there are two risk factors which are generally required for effective endocarditis. Number one, we must have a predisposing abnormality of the endocardium. So there must be an endocardium which is having abnormality, so that it can help for the bacteria to adhere easily. Number two, there must be a causative organism. That is, there must be bacteria within the blood. Rare massive bacteremia or particularly virulent microorganism can also cause endocarditis on normal valve. Remember, they said acute endocarditis is caused by bacteria which are very virulent and can affect normal valve. Endocarditis usually involves the heart valve. That is, when I was insisting in introduction, we said effective endocarditis is an inflammation of the inner lining of the heart, which is the endocardium, but it can involve the heart valve. Why? Because the heart valve they are covered by inner lining of the heart, which is the endocardium. Also, when we say the two factors required for developing effective endocarditis, we said there must be abnormality, pre-existing abnormality within the heart, and the presence of microorganism. So in pre-existing abnormality of the heart, it can be congenital heart defect. That is a pre-existing abnormality of the heart which can lead to effective endocarditis. Again, rheumatic valvular disease. Rheumatic valvular disease, we shall discuss this chapter in rheumatic fever with rheumatic valvular disease. Rheumatic valvular disease is a complication of rheumatic fever. What is rheumatic fever? We shall discuss it in rheumatic fever chapter. Also, there must be calcific in aortic valve or bicuspid valve, and the mitral valve prolapse can also predispose the heart valve to have effective endocarditis. The last is hypertrophic cardiomyopathy, which can cause hypertrophic cardiomyopathy leading to stasis of the blood within the heart, and this can favor microorganism to stay within to adhere within the endocardium and cause effective endocarditis. Prosthetic valve, these are particularly at high risk. As we said, the prosthetic valve can be affected even by less virulent microorganisms. That's where we had this subacute infective endocarditis. Subacute infective endocarditis, we said this is the endocarditis which is caused by less virulent organism and particularly affect already damaged valve or prosthetic artificial valve. Occasionally, neurothrombi, that is the thrombi occurring in the heart chamber, ventroseptal defect, patient with ductus arteriosus site can become infected. Of course, neurothrombi, remember, when you have a blood clot is a good culture media for favoring bacteria growth. The actual needles for infection is usually a sterile fibrin platelet vegetation formed when damaged endocardium cell release a tissue factor. So this becomes the actual site for infection starting. Infective endocarditis occur most often on the left side of the heart. Most common in the left side of the heart. About 10 to 20% of cases are right-sided. That meaning 80% occur in the left, while 20 occur in the right side. In intravenous drug abuse, these are patients who are at higher risk for the incidence of right-sided endocarditis. Why? Of course, they do inject blood within the vein, and the venous return is received by right chambers of the heart. So the right heart will be at right heart chambers will be at high risk of being infected with microorganism. So in etiology, we say microorganisms are the causative agent, and these microorganisms that infect endocardium, they may originate from distant sites such as cutaneous abscess. You may have a abscess in the skin leading to microorganism penetrating or traveling through the blood up to the endocardium where they cause infective endocarditis. Inflamed and infected germs, of course, these are also site for microorganism, and the UTI, urinary tract infection, can also be the source of microorganism. But they may also have obvious port of entry, such as central venous catheter and the IV drug injection site, as we have seen in IV drug abusers. Almost any implanted foreign material, such as ventricular or peritoneal shunt, prosthetic valve, these are putting patient to have a risk of being colonized by bacteria and therefore becoming the source of infection for infective endocarditis. Infective endocarditis may also result from asymptomatic bacteremia, typically occurring during invasive dental procedure. For this reason, that's why before dental procedure, patients do receive prophylactic antibiotic. Also can be due to medical procedure putting the patient at risk of infection and any surgical procedure. For example, in medical procedure, the patient can have a long staying catheter in situ and becoming the source of microorganism. Tooth brushing and chewing, usually due to Streptococcus viridans in patient with gingivitis. Again, as I said, in invasive dental procedure and the patient with gingivitis, they are at risk of having infective endocarditis, which is subacute, because it is caused in most commonly by Streptococcus viridans. These are normal flora of the mouth. These are less virulent microorganisms and they cause subacute infective endocarditis. The causative microorganisms vary by site of infection, source of bacteria, and the host factor. Of course, the host factor we said such as intravenous drug abusers. But generally, streptococci and staphylococcus are the most common and they count to 80 up to 90% of cases of infective endocarditis. The rest of cases are caused by other bacteria which are not staph and strepto. These are enterococci, of course they are gram-positive. We have gram-negative bacilli. We have high group of bacteria. We also have aerobic are not left behind, and the fungi also may cause infective endocarditis. As we have seen, Staphylococcus and Strep are the most common, though there must be a reason behind. And the reason behind is that they have ability to adhere in vegetation as compared to negative gram-negative aerobic. So that is the reason why gram-positive, Strep and Staph are the most common cause of infective endocarditis, having ability to adhere to vegetation as compared to gram-negative. So coming to pathophysiology of infective endocarditis, we say infective endocarditis typically occur at the site of pre-existing endocardial damage, as we saw. The virulent or more aggressive organism, which are staph and strep, are the most common cause of infective endocarditis. Infection tends to occur at the site of damage because these are areas which attract the deposition of platelets and forming blood clots. Hence, blood clots are the good media for bacteria growth. Avascular valve tissues and the presence of fibrin aggregates help to proliferation of organism and prevent these organisms from host defense. Clinical features in patient with infective endocarditis. Remember, because there is infection by bacteria which may cause inflammation, so fever, you are not surprised that the patient will have a fever. There also be a complaint of unusual tidiness. Why? Because when the heart valve are damaged, so even the heart will not be pumping blood properly. So the patient will have an unusual history of tiredness. So night sweat, of course, this explains that when there is low cardiac output, of course, particularly in the night when we are lying, the venous return is increased and this heart are not pumping blood properly, so they lead to congestion which causes to difficulty in breathing. That's why the patient they use a lot of energy to breathe and they have a night sweat. Of course, weight loss is explained by low oxygen. Low oxygen causes aerobic respiration to be favored more than anaerobic. Of course, the aerobic consume a lot of energy, a lot of glucose, despite producing low ATP, and therefore the body should use other source of energy such as fat, and this will lead to weight loss. And also there will be evidence of new sign of valvular dysfunction in echocardiogram. Remember, we said we make a diagnosis by having microorganism in the blood, evidence of microorganism in the blood, as well as the evidence of structural damage in echocardiogram. Infective endocarditis should be considered, we say, in patient with congenital or valvular heart disease, which develop features which are mentioned above. What featured? These are tiredness, night sweat, weight loss, and the fever. As we saw, patients with acute endocarditis do present with fever, but in subacute effective endocarditis, the fever is relative of low grade, but in acute endocarditis, they have fever of high grade. So remember, low grade fever is more like is seen in subacute, while high grade fever is seen in acute effective endocarditis. In patients with acute endocarditis, murmurs are heard on presentation in about 30 to 45 patients, but ultimately can be detected to 85% of patients as the valvula are progressing being damaged. Congestive heart failure may develop. Remember, when you damage the valve, you can have valvular incompetence or valvular stenosis. So valvular incompetence or stenosis can lead to heart failure. Occasionally, endocarditis associated myocarditis, that is inflammation of the myocardium, or intracardial fistula, that is the perforation of the endocardium, may cause congestive heart failure. Other clinical features include purpura, petechial hemorrhage in the skin, mucosal membrane, and the splinter hemorrhage under the fingernail. We can also have ocular node. What are the ocular node? These are painful and tender swelling at the fingertips. We can have finger clubbing, that is digital clubbing, which will be the late manifestation. In infective endocarditis, sometimes the spleen can enlarge and become palpable. Note microscopic hematuria is common in infective endocarditis. The diagnosis of infective endocarditis, as I said, is made based on what we say modified Duke's criteria. So to make a diagnosis of infective endocarditis, we have the criteria used, and these criteria are known as modified Duke's criteria for infective endocarditis. The modified Duke's criteria for infective endocarditis are grouped into two groups. We have major criteria, we have two major criteria, and we have minor criteria. Minor criteria are 8. So to make a diagnosis of infective endocarditis, please use the modified Duke's criteria, which is having major criteria, the 2, and the minor criteria, which are 8. Generally, those 2 major criteria and the 8 minor criteria of Duke's criteria, they are found by using blood culture. Number 2, echocardiography. Number 3, clinical criteria and the other lab investigation. We say blood culture and echocardiography, they give us major modified Duke's criteria. Why do they give us major modified Duke's criteria? It's because to have a diagnosis of infective endocarditis, number 1, there must be evidence of microorganism within the blood. And how can we have evidence of that bacteria? We must do blood culture. Number 2, there must be evidence of valvular damage. And how can we see the valvular damage? We have to use echocardiography. That's why we say the blood culture and the echocardiography, which give us evidence of microorganism and the evidence of valvular damage, forms Duke's major criteria. So the rest, which is the clinical criteria and the other lab investigation, will give us those 80 minor criteria of modified Duke's. So the 80 minor criteria are found by using clinical scenario and the lab investigation. Okay, major Duke's criteria, as I said, now we said in the major Duke's criteria, there must be evidence of microorganism. So how do we have the evidence of that microorganism? We have to take a blood sample and then do 3 culture of the blood. And in the 3 culture of the blood, we must at least have 2 positive blood culture having microorganism which are highly associated for infective endocarditis. We need to take 3 so that when we have 2, we can conclude that there is a microorganism. If you take it only 2, when you have 1, it will be 1 positive and 1 negative. It will be very difficult to say this is the presence of microorganism within the blood. So that's why we need to take 3 blood culture, and within 3 blood culture we must have at least 2 positive. Number 2, we must have evidence of echocardial involvement, that is structural damage of the endocardium in the echocardiogram. Of course, the echocardiogram can be either transthoracic, which is the most and the simple one, or transesophageal echocardiography. Minor criteria, which we said minor criteria, they are found from clinical history and the other lab investigation. Of course, presence of fever. Presence of fever is the minor criteria. We say the patient with infective endocarditis do present with fever. Presence of rheumatic valvular disease or congenital heart disease. We say the valvular heart disease and other congenital disease are putting the patient at the risk of having infective endocarditis. So they form minor criteria. Valvular phenomena, that is major arterial emboli. Remember, we said sometimes infective endocarditis can cause neurothrombi. Why neurothrombi? because valvular damaged and they distort normal blood flow of blood. They distorted the normal blood flow of blood, which is turbulent. It leads to blood stasis and forming emboli. Emboli favor microorganism growth. That's why we say major arterial emboli, septopulmonary infarct, myocardic aneurysm, intramural hemorrhage, and the conjunctival hemorrhage, as well as Jewish lesion. These are all minor criteria for effective endocarditis. The second issue is immunological phenomena. Immunological phenomena, that is when there is antibody and antigen reaction. This will lead to antibody and antigen complex, which are hypersensitivity type 3. So the position of this complex at any site can lead to inflammation. For example, when they deposit in the kidney, they will cause glomerulonephritis. Remember we said microscopic hematuria can be present in patients with effective endocarditis, and the reason behind is due to glomerulonephritis. Ocular node, of course, we said painful and tender swelling in the fingertips, that is ocular node, and the rosacea spots. All of these are due to immunological factors, and they also form minor criteria. Rheumatoid factor, of course, rheumatoid factor, we said rheumatic heart disease is a risk factor. Serological evidence of active infective endocarditis or blood culture which does not meet major criteria. Remember, the major criteria required to have 2 positive blood culture out of the 3 done. Assume you take 3 blood culture and only 1 become positive while the 2 are negative. So we say only when 1 is positive out of the 3, this is a blood culture which has not met major criteria. So because it has not met major criteria, it become a minor criteria. Number 7 is the predisposing risk factor. For example, when you have any condition of the heart which lead to predisposing of the heart to effective endocarditis, such as you have prosthetic heart valve, or you have any other valvular disease, or you have septal defect. So these are all risk factors for developing effective endocarditis. Other predisposing factor is IV drug abusers. Of course, also don't forget insisted much on intravenous drug abusers because they do inject drugs in an sterile way, and because staphylococcus are the normal flora of the skin, so they are at high risk of being infected, introducing staphylococcus within the blood. The last is echocardiographic findings, which are consistent with effective endocarditis, but it does not give us certificatory information to say to meet a major criteria. So you do echocardiogram, but you find it is consistency with effective endocarditis, but the information provided is not enough to say or to meet a major criteria. Remember, to make a diagnosis of effective endocarditis, we said generally we say definitive diagnosis of effective endocarditis require the following conditions. Number 1, when there is 2 major criteria, you make a diagnosis of effective endocarditis. What are the major criteria? Presence of microorganism out of 2 blood culture done, out of 2 positive blood culture. That gives us 1 major criteria, and the second major criteria is the presence of valvular damage in echocardiogram. Number 2 is when you have only 1 major, either you have evidence of microorganism in the blood or there is valvular damage on echocardiography. You have only 1 out of the 2 major, and you should have the 3 minor criteria. Remember the 3 minor, we had 80 minor criteria. Either there is a fever, or there is a predisposing risk factor, or there is a serological phenomena, or there is a immunological phenomena. Only 3 out of 80 minor and only 1 out of 2 major. So to make a diagnosis, we must have either 2 major, or 1 major and 3 minor. The last, when you don't have major, at least you should have 5 minor criteria. So when you have 5 minor criteria, without having any major criteria, they are enough for you to make a diagnosis of infective endocarditis. So if a person asks you, how can you diagnose infective endocarditis? We generally say infective endocarditis is made by using modified Duke's criteria. And how a definitive diagnosis is made, the definitive diagnosis is made when we have 2 major criteria, or when we have only 1 major and 3 minor, or when we don't have any major but we have 5 minor. The possible diagnosis of infective endocarditis, that is, there is evidence which are not fitting for infective endocarditis. We said to fit infective endocarditis is when we have 2 major, or we have 1 major and 3 minor, or we have only 5 minor. So assume you don't even have those 5 minor. So when you don't have those 5 minor, we say that is possible diagnosis, but not a conclusive or definitive diagnosis for infective endocarditis. In this circumstance, when there is only 1 major and only 1 minor, we said when there is only 1 major, there must be 3 minor to make a diagnosis of infective endocarditis. So in this circumstance, you have only 1 major and only 1 minor. That is possible diagnosis for infective endocarditis and not definitive. The second is when you have 3 minor. Remember, we said when you don't have a major criteria, you should have at least 5 minor criteria. But now you have only 3 minor criteria. So that is a possible diagnosis and not a definitive diagnosis for infective endocarditis. Now, what is a differential diagnosis for infective endocarditis? Remember, infective endocarditis may, of course, present with condition mimicking dysfunction in the heart. So rheumatic heart disease. This is a complication of the rheumatic fever which damage heart valve. So it can be a differential diagnosis of infective endocarditis. Congenital heart disease. Of course, congenital heart disease can also be a differential of infective endocarditis, because the infective endocarditis causes valvular damage within the heart. Myocardial infarction, of course, ischemia and infarction, they can cause congestive heart failure, and even patient with infective endocarditis with valvular damage can present with congestive heart failure due to valvular incompetence or regurgitation. Congestive cardiac failure may be secondary to hypertension, can also be a differential diagnosis of infective endocarditis, because the patient with infective endocarditis, they have high-grade fever, so septicemia and the presence of bacteria with the fever, they can cause septicemia to be a differential diagnosis. Note, positive blood culture remain the cornerstone of diagnosis and provide a live bacteria for both identification and susceptibility testing. To improve the outcome of the culturing bacteria, blood should be at least drawn at 30 minutes apart, each containing 10 ml of blood, and incubated both in aerobic and anaerobic environment. That is, to have a better result, you should take blood sample testing 30 minutes apart, because we need to do 3 blood culture. So we need to take at least 3 samples of blood, and these samples should be taken 30 minutes apart, and each sample should contain at least 10 ml of blood, and the incubation should be done in both aerobic and anaerobic. Of course, these are conditions which improve the results of blood culture. Why do we need to improve the results of blood culture? It's because blood culture remains the cornerstone of making a diagnosis of infective endocarditis. In investigation, it is better that the patient suspected of having endocarditis be referred for specific investigation at hospital level, because sometimes you might be in dispensary or health center where most of the investigations such as the echo and the blood culture are not done. Therefore, it is very important for this patient to be referred to higher center where the investigation possible for infective endocarditis are found. Other investigation which can be done at the hospital include blood culture, full blood picture, and the ESR. Of course, for septicemia, chest X-ray should be done to exclude pneumonia and other pulmonary pathology, as also to check for pathology of the heart such as cardiomegaly. Echocardiogram, as I said, it's very important to do echocardiogram so as to identify structural abnormality, which will give us a major Duque criteria. ECG is very important, that is to evaluate that is the functional abnormality of the heart. Pharmacological treatment. In treatment of the patient of infective endocarditis, consider for a negative blood culture, or if delaying treatment for blood culture or outweigh the benefit of starting treatment. That is when you see that because the blood culture takes a long time, such as maybe 3 to 4 days. So when you see waiting for results to start medication is not better. So you better initiate medication while waiting for the results. Or when the patient are very risky and negative blood culture will put the patient at risk for delaying treatment. That's why we can initiate empirical treatment. Remember, empirical treatment is a treatment done without investigation. So effective endocarditis for native valve can be treated by antibiotic such as benzyl penicillin. Of course, the dose is indicated here, and the duration can be given 4 to 6 weeks. So another drug we can use ceftriaxone, of course, 2 gram IV daily for 4 to 6 weeks. We can add also chlorhexidine to cover staphylococcus. Remember, chlorhexidine, these are staphylococcal antibacterial. So 2 gram IV 6 hourly for 4 to 6 weeks. You can add also gentamicin, that is 1 to 1.5 milligram per kg 8 hourly, at least for 2 weeks. Methicillin resistance staphylococcus aureus, please consider giving vancomycin. Of course, the dose is indicated here, and the duration should at least be 4 to 6 weeks. Okay, we are continuing with the treatment in prosthetic valve, that is artificial valve. You can give benzyl penicillin again, ceftriaxone again, plus chlorhexidine, plus rifampicin, and the genta again. Remember dosage, patient with normal renal function. So it is better to consider renal function in planning for the dose of the drugs. It is important also to assay gentamicin level every 3 to 4 days. 1 hour peak concentration should not exceed 10 mg per liter for the dosage of gentamicin. At any stage, treatment may have to be modified according to detailed antibiotic sensitivity. Remember, you can have initiated empirical treatment. So when the culture is done and the sensitivity results are out, so you can change antibiotic depending on the sensitivity. Also, you can modify the drug depending to allergic reaction. So maybe initiating the drug, you may be initiating the drug which induce allergic reaction to the patient. So consider changing that drug. Failure of response endocarditis leading to significant cardiac failure or failure to respond to antibiotic may require early cardiac surgery within a few days. Remember, we said in introductory part management modality of the patient with infective endocarditis is antibacterial, and sometimes surgery can be indicated. In prophylaxis of infective endocarditis, of course, antibiotic should be given in any patient who are at risk of infective endocarditis. Who are these patients who are at risk of infective endocarditis? These are patients with prosthetic heart valve, including transcatheter valve, and those with prosthetic material used for cardiac valvular repair. Also, patients with a previous episode of infective endocarditis. These are patients who should receive prosthetic antibiotic. Also, patients undergoing dental surgery should also receive prophylactic antibiotic. Patients with congenital heart disease also should receive prophylactic antibiotic. Prophylactic antibiotic is not recommended in other valvular disease or congestive congenital heart disease. To reduce the risk of bacterial endocarditis, antibiotic prophylaxis should be given to patients undergoing dental procedures, because we saw in dental procedures Streptococcus viridans, which are normal flora in the mouth. They can easily enter within the bloodstream and cause subacute infective endocarditis in patients who are already having pre-existing pathology within the heart. Antibiotic prophylaxis is not recommended in respiratory tract procedure, so you don't give antibiotic. GIT, urology, and transesophageal echocardiogram, we don't give prophylactic antibiotic in this patient. Also, gastroscopy, colonoscopy, cystoscopy. Of course, gastroscopy, this is endoscopic procedure to visualize the stomach. Colonoscopy, endoscopic procedure to visualize the colon. Cystoscopy, endoscopic procedure to visualize the urinary bladder, vagina or cesarean section, as well as the skin and soft tissue procedures. We don't give antibiotic prophylactic for infective endocarditis. Recommended prophylaxis for high-risk dental procedure. In high-risk patient, we have situation, antibiotic, and dose indicated. We have amoxicillin or ampicillin. You can also use clindamycin. Alternative, cefalexin and cefazolin or ceftriaxone can be given. Cephalosporin should not be given in patient with anaphylaxis, angioedema, or urticaria after intake of penicillin or ampicillin due to cross sensitivity. Complication, of course, let us have a look on complication of infective endocarditis. We can have valvular dysfunction. That is one of the complications due to valvular damage. You can have myocardial septal abscess. You can have congenital heart failure. Of course, this is due to valvular incompetence or stenosis. You can have metastatic infection. Of course, infection going to another organ and causing infection. We can have embolic phenomena. Of course, distorting of valvular structure lead to disturbance in normal blood flow, which lead to embolic phenomena. Organ dysfunction resulting to immunological process. Of course, remember glomerulonephritis, which was caused by hypersensitivity type 3, can lead to renal failure. Untreated infective endocarditis is always very dangerous, so the patient is at high risk of losing life. So even with the treatment, death is more likely and the prognosis is generally poor. Poor in which patient? In older patient, people who are having infection with resistant microorganism, or people who are having infective endocarditis but also have other underlying disorders, or long delay of treatment. That's why we say it's better to initiate empirical treatment rather than waiting for the result. Prognosis is also poor for people with aortic or multiple valvular involvement and larger vegetation, polymicrobial bacteremia, prosthetic valvular infection, myocardial aneurysm, right ring valvular ring abscess, or major embolic event. Mortality rate for viridans, streptococcus endocarditis without major complication is only 10%. Of course, viridans streptococcus, these are less virulent and they cause subacute infective endocarditis, but the mortality is usually 100% in aspergillus endocarditis after prosthetic valvular surgery. Prevention. So how can you prevent infective endocarditis? Make sure that antibiotics are being administered in conjunction with selected procedures which put the patient at high risk of infective endocarditis. Which are those procedures? Again, to insist dental procedures. Maintaining a good oral hygiene is probably more effective in overall prevention of infective valvular infection because gingivitis is the most common source of spontaneous bacteremia. Prevention of valvular catheter infection is an important prophylactic approach in preventing nosocomial, of course, hospital-acquired infective endocarditis. So that marks the end of our discussion, and to summarize, infective endocarditis commonly occur in pre-existing endothelial damage which attract the deposition of fibrin and platelets where blood-borne microbes are attracted to vegetation. Again, infective endocarditis is common in already damaged endocardium. And number two, we say infective endocarditis should be suspected to a patient known with congenital heart disease whenever they develop persistent fever, tiredness, and weight loss. Okay, to finish, let us evaluate ourselves. Number one is, how will you manage a patient who you suspect to have infective endocarditis? Of course, remember how we said to mention antibiotic use. We said you can do it empirically without waiting for the results. How do you prevent infective endocarditis occurrence? We said infective endocarditis can be prevented by providing prophylactic antibiotic and in any procedures which puts a patient at high risk of developing infective endocarditis, such as dental procedure, also maintaining good oral hygiene. The last is discusses the complication of subacute endocarditis. Thank you.